Dr. Eugene. Is that okay?
Yep.
So I think you should be able to share your screen now.
Okay. All right. Can everyone see?
Yeah, we can see.
Okay. Hold on. Right, so good afternoon, everyone. My name is Eugene Wong. I'm an ENT surgeon currently working in Malaysia. So it's about 8:41 p.m. over here, and I hope everyone is keeping safe in the UK. So first of all, I'd like to thank Anglia Ruskin University Surgical Society for inviting me to give a talk as part of your academic webinar series. So today, my aim is to give a good insight into what we do as ENT surgeons, and hopefully motivate and inspire some of you to take on this exciting career path in the future. So just before we start, just a bit of brief introduction to myself. So I studied in Aberdeen Medical School in Scotland, class of 2008. And after that, I've worked for the NHS for 6 years in Stirling, Glasgow, Gloucester, Cheltenham, Middlesbrough, Truro, and Cardiff. And after that, I moved back to Kuala Lumpur, and then to Switzerland, in Basel, back to KL, and currently I'm working as an ENT surgeon in Kota Kinabalu on the Borneo Island. So this is the picture of the Queen Elizabeth Hospital where I'm working now. And this is the entrance to the campus of the medical school that I'm working at. And this is also from the medical school campus. So they actually have their own beachfront, which is quite nice. And the city itself is beautiful as well. So this is taken along a running track that I go to, which is next to the South China Sea. And the city is voted to have one of the best sunsets in the world. And just a few hours drive away, we have Mount Kinabalu, which is the tallest mountain in Southeast Asia, about 4,000 meters above sea level. So here's how I'm going to run the session today. So I'll tell you why I've chose to do ENT with some examples of what we do on a daily basis, followed by some advice on what you can do to find out more about the specialty and how to improve your CV for ENT, and some question and answer at the end. So let's get started. So some of you may have seen this type of algorithm before. So this is the only one that I found that included ENT as part of it. So from here, you can see that they say if you are sane, not too hardworking, afraid of the dark, think small, and likes red or pink, then ENT is for you. So if you find this accurate, then good for you. But most of us actually choosing a specialty is not that straightforward. So let me just tell you a bit about my personal journey into ENT. So my career choice have actually changed quite a number of times since I was a medical student. Well, I've always known that I wanted to become a surgeon. And I assume that if you're in this ARU Surgical Society, you probably lean more towards surgical field as well. But I've always wanted to become an orthopedic surgeon throughout my medical school and FY1. And I make sure that all my CV, it's all about bones. So my electives, my prizes, research. And this is mainly because the trauma and orthopedic has always been my favorite rotation during my undergraduate. And we get a lot of hands-on experience in OT to do some hammering of nails and screwing some plates. And like most medical school around the world, we only have 2 weeks of ENT exposure in the entire 5 years. So it's quite limited. But when I finally get to become an orthopedic FY2 in Western Infirmary in Glasgow, I've realized that working is actually very different than being a student who are attached to the department to observe and to be taught. So I find myself not really enjoying the cases that I see every day, the type of patients that I have to manage, and even the operations itself. I lean more towards smaller, finer operations that require more delicate, precise hand movements compared to larger maneuvers. So I felt a bit lost and went into a general surgery or urology themed core surgical training program, which I didn't quite like it enough to want to do it for the rest of my life as well. So what happened was one day when we were running around trying to sort out some general surgery emergencies in the operating theatre at Gloucester Royal Infirmary, and I looked across the room in the coffee room, and I saw two surgeons who were just looking really relaxed, waiting for their case on their laptops, chatting away. So I asked one of my colleagues, who are these people? Because I want to be like them. And they told me they are ENT surgeons. So I've asked if I can do some attachment at a department and in their OT to find out more about the specialty. And during those attachments and conversation, I've realized that this is actually what I wanted to do for the rest of my life. And I'll tell you what actually attracted me to the specialty. So first of all, there's a wide range of variation when it comes to patients' age that we see every day in our clinics and during on-calls, which in turn also means that we perform procedures and operate on patients from different age range all the time. So for example, in a normal clinic, we might be seeing a pediatric patient, like an infant with laryngomalacia, or a child with foreign bodies, or like in this case, an infected lymph nodes, and the next patient that walks in might be an adult with deviated nasal septum or allergic rhinitis. And after that, we'll have a 70-year-old with a parotid malignancy, for example. So in comparison to other specialties in surgery, most of the pediatric surgical fields are actually quite subspecialized. For example, pediatric orthopedics, pediatric general surgery. So as a junior doctor, you rarely get to see patients from both age spectrum in one rotation. Whereas in ENT, you get to examine and treat all these age range from the start of your rotation as a junior doctor. So the next thing that attracted me to ENT was that we cover a huge range of pathologies. So ENT is really not just about ears and earwax and snots. So for example, in ear, we cover balance as well. For the nose, we cover the skull-based pathologies, and there is facial plastics, there's voice, allergies, and sleep surgeries. So during our daily work, we see all types of pathologies that can range from trauma, for example, an exposed cartilage of the ear, infected neck. And this patient, so this is actually the nostrils, and this is the mouth. So we remove about 400 maggots from patient's nose. So this patient actually have underlying B-cell lymphoma with maggot infestation. And then the next patient that you see will have a huge tumor fungating out from the neck. And because ENT are frequently, well, the ear, nose, and throats are frequently interrelated. So quite often, patients actually present with problems in more than one system. So a good example is nasopharyngeal carcinoma, which is actually very common in my part of the world, because of the location of the tumor, which is in the nasopharynx. So it's at the back of your nose. So patient will present with epistaxis, with unilateral nasal obstruction. But because of the location of the tumor next to the opening of the eustachian tube, so patient will have hearing loss due to underlying otitis media with effusion as well, because the tumor was blocking the eustachian tube. And 80% of the patient will present with a neck lump due to the spread of the disease. So it's interesting to get to diagnose and manage different aspects of the disease in one patient together with oncology team. So another reason for doing ENT is that we get to provide patients with both medical and surgical treatments. So many actually say that we get the best of both worlds because we have our clinics and wards where we prescribe medical treatments to the patient first. And if it doesn't work, we always have the option to bring patient to the OT to operate on them. So there's always a continuity of care in our patients. So for example, a patient with epistaxis, so we will treat them with first aid maneuver, with cauterization or packing. And if it doesn't work, we will bring patient ourselves to OT for sphenopalatine artery ligation, for example. Similarly, for a patient with tonsillitis or infected preauricular sinus, so initial treatment would be conservative with antibiotics, with painkillers. But if it keeps recurring, then we can bring patients to OT to do tonsillectomy or to excise the tract down to the cartilage. And this is another example. So nasal polyps is also very commonly seen in our clinic. So we always start with medical treatment first, with nasal spray, with oral steroids, and nasal irrigation. So all this to try to shrink the polyps. But if it fails, we will take patients to do endoscopic fast polypectomies. So compared to other surgical fields, there's usually a division between the medical and the surgical specialty. So examples are like for your heart. So the cardiologist would treat your patient's heart medically, but if there's any operation that needs to be done, they'll be sent to the cardiothoracic surgeons. Or gastroenterologists, they would treat your medical problems with your GI tract. But if patient needs operation, you send to the general surgeons. But there's not really any equivalent medical specialty for ear, nose, and throat, where we can send our patients to them to be treated medically. And therefore, we get to treat all our patients with both medical and surgical treatment. So the other reason that attracted many of us to do ENT is because it is a very rewarding specialty, because we actually help patients restore many of their essential functions and senses. So for example, for ears, we restore patients' hearing and balance. And for the nose, we help them to be able to breathe and smell again. And for the throat, we help them restore their ability to talk, communicate, taste, swallow, and breathe. So patients really do appreciate what we do for them. And even for a simple procedure like removing impacted wax from their ears, and therefore allow them to be able to hear again, and therefore able to listen to their music and able to talk to their loved ones. So sometimes we may not appreciate how important these senses, these things are. And I usually ask the students to imagine if I've asked you to wear 2 earplugs for 5 days. So everything would sound muffled around you. And therefore you have to turn up the TV volume. You can't hear what your friends are saying. And they might get offended because they think you're ignoring them, and they'll stop trying to talk to you as well because they know that you can't hear them anywhere. So this is actually what many of our patients with hearing problem experience. So it really does affect your quality of life. And what we do is essentially removing those earplugs from your ear by doing microsuction, by inserting a grommet to drain the fluid in the middle ear, or repair perforated eardrum, or do a stapedectomy or ossiculoplasty to establish the ossicle functions, or cochlear implants. And besides that, the impact of ENT pathologies on patients' occupation is quite big as well. For example, restoring balance in those who have to work in construction at high altitude, restoring sense of smell and taste in chefs, treating obstructive sleep apnea so that bus drivers can get their license back from DVLA, or restoring voice in professional voice users like singers and teachers. And for those who enjoy using gadgets and technologies, so this is also a perfect specialty for you, because starting from even basic examinations as a junior doctor, you will need to be able to learn and use microscope or autoendoscope for the ear, flexible or rigid endoscopes for nose and larynx examination. And you can display this on high definition monitor and attach it to your phone and get pictures and videos of your findings from there. And even in the clinic itself, you get to perform various procedures using these telescopes and microscopes, such as microsuctions, removal of foreign bodies, injection laryngoplasty for vocal cord palsy, or injecting steroid into the middle ear for those with sudden sensorineural hearing loss. And even in operating theater, you get to use even more gadgets. For example, you can, for endoscopic sinus surgery, you can use it with IGS, the image-guided surgery, which allows you to see exactly where you are in terms of anatomy of the sinuses. You can use lasers for vocal cord pathologies. You can use robots where the surgeons would be controlling the robotic arms from the console. So usually in ENT, we do this for tongue-based CA or tonsillar CA. And this is actually from my previous hospital in Kuala Lumpur, where they perform bilateral cochlear implant using this Vitam 3D system, which basically they wear 3D glasses and they operate without microscope, because there's a scope here from outside that can actually magnify and project a 3D image on the screen. So another important thing to consider when choosing a specialty is the people that you work with every day. So in ENT, we are generally very enthusiastic about our work. We are more laid back, more soft-spoken, and generally have a good work-life balance. So you should really look for a specialty that you feel that you can fit in easily with your colleagues, because they are the people that you'll be seeing and working with every day. So during medical school, I've always resisted this idea that there's any stereotype in terms of personality for each specialty, like those in the algorithm. But actually, when I started working, I have to agree that certain specialties do attract certain types of people and personality. And this is very similar across all the hospitals that I've worked in different countries. So all I want to say is, when I joined ENT, I felt that I fit in very well with the rest of my team and with my colleagues. So it is actually a very important part to consider when choosing a specialty. And finally, I've added this as an attraction to the specialty. although sometimes it can be a double-edged sword. So in ENT, we generally don't get too many emergencies during on-calls that require emergency operations. But when we do get them, they are usually airway problem that needs to be sorted immediately. Because if you recall in your resuscitation guideline, it's always A, B, C. So airway is always first. So if you can't get air into the lungs, even if your breathing is fine, your circulation is working, the bloods will still be deoxygenated and you won't survive. So we actually share the airway with the anesthetist and work very closely with each other. So anesthetists will usually refer difficult airway patients that they are unable to intubate for us to do either bronchoscopy or tracheostomy. So since I started working in Sabah or in Borneo Island, I've actually performed many emergency tracheostomies on patients because they generally come in quite late. And many of those were done under local anesthetic with patients being awake as well because they were not intubatable. For example, due to a large tumor that's obstructing the airway or very severe subglottic stenosis. So this patient, for example, can mean with an extensive tumor that's causing medialization of the supraglottic tissue. So they will come in with stridor. And the challenge is that externally, as you can see here, there's really no neck left that you can palpate or see where the trachea is due to this tumor that's extending into the submandibular and sublingual, submental area. And the other problem is because of the extent of the tumor, patient is unable to extend the neck to bring the trachea forward for us to palpate as well. So luckily, we managed to do a awake fiber optic intubation through the nose. And after that, the challenge was for me to slowly explore the neck to find where the trachea is. So, patient successfully had a tracheostomy done to secure the airway before we then can take biopsies and find out what kind of tumor this is. So it can be quite scary thing because patient can desaturate very quickly in front of you and you might lose the patient because of the airway issue. But at the same time, you are saving patients' life in the most literal way by re-establishing their airway for them. So what is my typical week like? So I can only speak for pre-COVID time because at the moment we're undergoing second lockdown. So all the elective activities are cancelled. But in a normal week, I would have 2 clinic days and 3 OT days. And we start with ward rounds in the morning. And after that, you either go to the clinic or operating theater. And if you're on call, you have to attend to any emergencies that might come up. And because I'm also employed by the university, so I have other extra activities that I need to do when I'm not in the hospital. So for example, teaching. So this was, or giving talks. So this was at the ENT GP Symposium, or doing research and innovation, or attending courses. So this was at the Chinese University of Hong Kong, or setting up community outreach program like the one that we did in a rural area in Borneo. So what can you do to find out more about ENT as an undergraduate? So I would suggest, number one, you can speak to the consultants and registrars in your hospital about getting additional placements during your undergraduate, because I believe most medical schools are still having very limited exposure to ENT. And the other thing to do is you can always ask them if there's any research or audits that they are doing in their department that you can be part of. And most of the time, they're more than happy to let you be part of their projects. The other thing is you can do elective in ENT departments in other parts of the world. For example, we do have elective program in UMS in Sabah. So I'm more than willing to accept any elective students if you want to come over to this part of the world after when you're allowed to travel again. So you can contact me about that as well. Other than that, it's also very good to get an actual job in the department to see what it's like to work there. So maybe during housemanship or during SHO job. So if you have decided to go into ENT as a career, there are things that you can start doing for your CV as well. For example, you can consider taking exams in your foundation years, either MRCS, ENT, or DONS. You can think about entering entering competitions to get some prizes and awards, attending ENT-related courses, for example, temporal bone, FAST, neck dissection, or airway course. You can also look at how you can be involved in research and audit activities in ENT departments, even if you're not working there. And with the results, you can publish and present them in different conferences. And you can also find ways to be involved in teaching and managerial activities in your department and participate in any extracurricular activities like outreach programs. So in conclusion, so all of us will have different reasons or motivation to choose the specialty that we want to do. So it could be because of the location of the hospital, because of your past working experience, your personal or family history with the specialty that inspire you to go down the path. So just remember that all of these are valid reasons for you. And the most important thing is that you enjoy what you do and enjoy the people that you work with, so that when you come to work every day, it doesn't feel like work, because this is something you're going to do for long term. And for me, I can honestly say that ENT is, when I go to work every day, it doesn't feel like I'm working for ENT. So another thing to remember is that you don't have to decide too early what you want to do. And even if you have decided, you can always change your path, like how I did. So here are my contacts. If you have any questions about either ENT, career pathway, doing your elective over here, or just coming to Borneo for holidays, so don't hesitate to contact me. So thank you very much. So that's the end of my presentation.
Thank you so much, Dr. Wong. That was an incredible presentation. We
you.
have a couple of questions that have come in. So
Okay.
one of them is, how is the ENT training pathway different in UK and in Malaysia?
So I think in UK the training is slightly longer. So it's so you have to do CT1, CT2, and ST3 to ST8. So it's it's 8 years, whereas in Malaysia it's 4 years. So also the same. So after you finish your you have to be a SHO for a number of years, and then you apply into the training program, and the training program is 4 years in duration. And this is actually similar to many other countries as well, like Singapore. I think US is also about 4 years, and Switzerland as well, it's 4 years. So UK is slightly longer, but I think for UK, when you come out from the training, you can be a consultant straight away, whereas for other countries, you would be, well, maybe it's called a junior consultant first before you become a more senior consultant.
Okay, that's actually quite interesting. Another question that we have is, because of how specialized ENT is, do you find yourself working with other specialist surgeons, such as vascular surgeons or neurosurgeons?
Yeah. So actually, we do work a lot with other specialties. So, for example, in a complex head and neck cancer case, there's always plastic surgeon who would help us to do flaps at the end. There's always, we also work very closely with the oral maxillofacial surgeon because our areas do overlap quite a lot, or in some of the cases. For example, we would be doing the neck dissection, whereas they would be doing any involvement of the maxilla. And we also work closely with the neurosurgeon because part of the rhinology involves skull base as well. So we would open up the skull base for them to then operate through the openings that we've given them to remove, for example, a pituitary adenoma. So there's quite a lot of and also ophthalmologists, because of how sinus infection can always cause ophthalmology problems because it can spread to the eyes. So we also work closely with them.
That's brilliant. Another question is, so I know you said in your talk that you're part of ENT, that the part of ENT that attracted you was the different technology that you were using. How do you think that the specialty is constantly changing with the new developments in technology?
So it's definitely changing quite a lot even from the time when I first started ENT, where I came from a hospital where we were still using the mirror and the bull lamp to look inside patients' oral cavity, or using laryngeal mirror, and even up to now, some hospitals are still using laryngeal mirror. But as I progress through my career, now most people are using scopes. They are not using mirrors anymore. And for example, ear operations, previously it's always been using microscope to operate on ears. But now we're moving towards using autoendoscope and operating from the ear canal itself. A lot of cholesteatoma surgery that can be done directly from the ear canal without making any incision at the back of your ear for mastoid drilling. So there is it's constantly changing. For example, the picture that I show you about the 3D Vitum thing as well. So this would have never been imagined before, that you can actually just wear a 3D glass and start operating without looking through like a microscope to do. So I suspect it will continue to evolve as well.
That's really good. So do you think that you're having to train yourself with the new machines, if they're coming in?
Yeah, so usually the company will always send someone to train you to use their own technologies. Yeah.
That's really good.
It's quite an exciting thing for us to learn new things and see new technologies. Yeah.
Brilliant. Another question that we have is, what can we do as medical students now so that we can, get into ENT?
So as into the ENT training program, or?
Yeah, how can we become more competitive in the training pathway? What can we sort of do at this level to develop our interest in it?
Okay, so that was my I think the second last slide. So I can send a slide to you guys after this as well. So what I've listed down is actually how you gain points in your ST3 application. So if you can start ticking those boxes even from now, that would be very useful to start accumulating those points. So for example, so the main thing is to show commitment and dedication to the specialty from the beginning. So for example, going for elective in ENT, and from there, you can then generate research studies that's related to the specialty, then hopefully it can be published. So all this give you points here and there to get you into the ranking that's required for you to get into the training program. So all this can be done as a medical student because even when I was a medical student, I did already went around to ask the orthopedic guys whether there's any audits that I can help them with and any papers that I can write, any data that I can collect for them. So all these things you can actually start doing now as well. And especially with current Zoom and all these meetings. So I think you can present even easier now without having to actually travel or spend money for the conferences and get your certificates of presentation from there.
Thank you. So how do you find the work-life balance within the ENT specialty?
Okay, I would say it's definitely one of the good ones that in terms of surgical field, in terms of surgical specialty, because as I said, it's very rarely as you go up the rank or go up in terms of seniority that you actually need to come in to operate on anyone during your on-call. So most of the time it can be sorted at a more junior level. So that means your on-call is not too busy, except when there's airway, then you need to come in to sort out the airway quite urgently. Compared to other specialty, which because I have actually worked in a lot of other surgical specialty, cardiothoracic, general surgery, orthopedics, urology, they are generally quite busy, and quite often we need to bring patient in, for acute appendicitis that we need to do an appendicectomy, for any, hernia, strangulated hernia, or perforated bowels. So all these things actually happen quite often. Or for trauma, so patient break their bones. And even for neurosurgery as well, there's a lot of, road traffic accidents where you can't wait. So you have to come in the middle of the night to operate on patient.
Wow. Okay. So another question that we have is, are there any downsides of having a career in ENT? And is it true that the learning curve is quite steep?
Yeah, so I think that kind of answers the question. So I guess the downside is that because we don't actually get much teaching in ENT during our medical school time. So when you started going into work in ENT, it's as if you don't know anything. So the learning curve is quite steep, actually. So which is what I've experienced myself as well, because when I went into ENT, I have to read from the start because I don't remember any of the things that were taught in that 2 weeks out of 5 years. And also in terms of exams as well, I remember the focus was never on ENT. So you don't generally read much about those conditions as well. So that is one thing. Another thing is also related to learning curve is that everything is so small, and usually when you try to operate, for example, because everything is so small and it's designed for just one person to do it. Therefore, it's more difficult for you to learn how to operate on those things, or assist the surgeon in those small operations, compared to, for example, general surgery. Because you can do a laparotomy, and you get to stitch everything up, and you can touch, and you can have quite a few people around the patient to learn. Whereas a tonsillectomy, for example, there's no room for another person really. It's a one-man's operation, or the most is another person, and you can hardly see what's inside the oral cavity. So those are probably the downside in terms of training.
Yeah, I definitely agree with you. I think we had 2 weeks of ENT, and we definitely thought if we had a couple more weeks, we could have experienced it a lot better. And yeah, I also agree with the surgery, especially when we're doing dissections. It's very hard to actually see what's going on. So I can imagine when you're doing a surgery, you can't have that many people around. Another question is, how can we, so you mentioned that you'd worked in Switzerland. How did you find that experience, and how can we sort of get to work in different countries as well?
Okay, so the Switzerland one was actually because one of the one of the senior surgeon there went to my hospital at that time in Kuala Lumpur to do his fellowship in skull-base surgery. So when he went back, he basically said, "Oh, why don't I arrange for one of you guys to come over to attach for a year as well, as part of the training." So that was kind of the arrangement. But what I can say is, one of the good way to do it is through research, which is what I did as well. So when I went there, it was paid for by the research grant. So my main job was supposedly to help them to come up with a research idea and try to do research there. But at the same time, you get to go and go to the OT, go to the clinic. So that's what I would advise people. You can always email them and ask whether they have research grants available to hire someone to come there and get that experience.
That's great. So another question that we have, so you're currently working in Malaysia. Do you think, do you obviously speak to the patients in a different language, and do you feel like do you have to learn medical terminology in the different language as well? How did you find that?
Yeah, so it was difficult when I first came back here, because I was living in UK for 11 years. So when I went home, I have to relearn the language. But because in Malaysia, everyone can speak at least 3 languages. So Malay is the national language that everyone would have learned when they were young, and then everyone speaks English in this country. So that is a good part as well. So for UK medical students to come here, it shouldn't be a problem, because everyone can speak English, and then you can speak. So only some patients may only be able to speak Malay or Chinese, but you can always find someone like a nurse in the clinic to help you translate as well. But most people understand at least some basic English here.
That's good. I had a question. So do you think that there's certain pathologies that you're seeing which are more prevalent in Malaysia compared to perhaps what we would see in the UK?
Yes, so definitely. So mostly, so there are 2 things. So one is certain pathologies are more genetic related. So for example, NPC, it is more prevalent among the Sabahan, the Borneo people, and in the South Asian population. So that one is understandable. The other thing that I see way more here are all the complications that you only read in books in UK that basically theoretically this could happen if you don't come to the hospital early. So those things I've never seen during my time in UK, but when I come back here, that's all I see all the time. For example, we don't see like tonsillitis. We see parapharyngeal abscess, which was from tonsillitis, which were not treated because patients have waited so long that when they came here, it was already a deep neck abscess, which doesn't quite happen in the UK because they will come to seek treatment when it was still tonsillitis. And for cancer, so another thing that that is quite sad here is the traditional medicine as well, which a lot of people still believe in them, especially in the rural population. So even if you diagnose their cancer very early and tell them, you can cure them, they always opt for traditional herbs or some, well, like witchcraft type of things in their village. So, and then a few years later, they will come in with a fungating tumor that has metastasized. So, there's nothing that we can do anymore. So that kind of cases we see quite a lot. So, which doesn't quite happen in UK as well.
I think that's really interesting. So would you suggest, how training in different areas of the world so you can probably see how things change, even within a specialty, but how they change geographically?
Sorry, what was the
question? The question was, would you suggest training in different parts of the world so you can see how pathologies change?
That would be interesting, but I think if you've decided where you're going to practice for long term, so probably you won't really see those pathologies in other parts of the country. So it may not be too useful, but it's always I guess if you may still from time to time see something weird from patients who may be traveling from other parts, for example. So that's what happened in Switzerland as well, where from time to time there will be someone who say, oh, I'm coming from, I was traveling from Indonesia, for example, and they present with some weird stuff. So if you have probably seen that before, then it will help you with the treatment, I guess.
Thank you. So I think that is all the questions that we have for today. We just wanted to say a massive thank you. I know it's probably evening now for you, but we really appreciate the time that you've taken to talk to us today.
Nope.
I don't know if anyone has any final questions. No? Okay. So thank you so much, Dr. Eugene. We look forward to seeing you again next Wednesday for another amazing talk.
Okay, thank you so much.
Thank you so much.
Thank you.
Thank you. So Dr. Eugene has another talk next Wednesday where he's going to be talking about management of common ENT conditions. So we hope to see you all there. So I'm going to close the meeting now. Thank you all for coming, and we'll see you soon.